All right, I think we can go ahead and get started. Everyone's ready. Welcome to the 2021 Head and Neck Cancer Survivorship Symposium, hosted by the Head and Neck Cancer Alliance and the American Head and Neck Society. Our session today is on dysphagia and swallowing challenges. My name is Dr. Vilija Vaitaitis. I'm an assistant professor at the LSU Department of Otolaryngology Head and Neck Surgery here in New Orleans, and I want to thank you all for joining us today. I'd also like to thank Mr. Ed Steger and Dr. Kate Hutcheson for taking part in this webinar discussion with me. Now I'm going to introduce each of my co-presenters. So first, Mr. Ed Steger. He was diagnosed with squamous cell carcinoma at the base of his tongue and oral cavity back in 2005. After hitting some rough patches in 2006 and 2007, he's had no evidence of disease since October 2007. Ed's dysphagia is severe and began in mid-2006 after a 12-hour salvage surgery, which required removal of his left lower jawbone, part of his tongue at the base, and a quarter-sized hole in the soft palate. He became the volunteer president for the National Foundation of Swallowing Disorders on September 1st, 2012. Next, we have Dr. Kate Hutcheson. She's a professor in the departments of head and neck surgery and radiation oncology at the University of Texas MD Anderson Cancer Center. She serves as chief of the section of speech pathology and audiology, and she's a lecturer at the University of Houston. Dr. Hutcheson is a certified speech-language pathologist with a doctorate degree in epidemiology, and she leads a practice-oriented clinical research laboratory with funding support from the NIH, PCORI, Foundation, and donor funds. Dr. Hutcheson is a board-certified specialist in swallowing and swallowing disorders. We're very lucky to have both of them today here. So for today's Dysphagia and Swallowing Challenges webinar, our presenters will offer their comments, and afterwards we will open it up to the audience for questions. To ask a question, they're welcomed either by the chat or by using the waved hand function at the 30-minute mark or through the Q&A at the end of the presentation. To raise your hand in Zoom during a meeting, you can click on the icon labeled Participants at the bottom center of your PC or Mac screen. And at the bottom of the window on the right side of the screen, click the button Raise Hand. I'll try to keep an eye on everybody and answer as I can. On some of the screens, this could be marked as a reactions button. All right, for today's session, again, Ed and Dr. Hutcheson plan to review some of the most frequently asked questions of the NFOSD from patients and their caregivers and hopefully provide some guidance and insight. As we all know, dysphagia is an unfortunately common side effect for head and neck cancer patients, with over 60% of patients experiencing some form of dysphagia or swallowing disorder post-treatment, and 50% of patients reporting a decrease in their quality of life due to these effects. Dysphagia can affect all phases of head and neck cancer care and can be challenging to diagnose and effectively treat. So one of the first questions that we want to address today is, as a newly diagnosed head and neck cancer patient, the timing of seeing different medical disciplines has been confusing and overwhelming. Is this normal, and what is the best way to navigate this? I'll turn it over to Dr. Hutcheson to start.
Thanks so much, Phil, and also to the HNCA and the AHNS for organizing this symposium that's really focused on providing information to patients, families, caregivers, and also specifically to Ed and the team at NFOSD for helping to compile a list of real-world questions that are coming in from patients surrounding swallowing difficulties and head and neck cancer so that we could really structure today's program around these issues. And so I think this first question that we see here today really emphasizes the sort of deluge of information that can come to an individual right around the time of their diagnosis and then as they're preparing for their treatment. And what I thought I would do in the next series of slides is just try to walk through the sort of clinical perspective on what we're trying to accomplish prior to treatment to help support a head and neck cancer patient with the best recovery of swallowing possible. And, you know, I think part of the sort of overwhelming amount of people and information sort of reflects an evolution in head and neck cancer care over the last several decades that has occurred with a goal of trying to prioritize interdisciplinary care, recognizing that there's value in integrating messages from multiple clinical perspectives earlier in the cancer journey. And the idea of this is specifically with regard to side effects to try to help proactively manage those issues before we get to the point of crisis management. So one of the ways that the field has tried to really implement this interdisciplinary care is through the development of clinical care pathways. And this is just an example of one that you see on the screen here. And it looks complex, but the goal is to actually try to organize when and who is going to insert into care, the head and neck cancer care of an individual patient at key time points. There are lots of providers that are included in these interdisciplinary pathways. And you can see just some examples on this diagram here, where in red, we see the primary treating oncology team, the physicians and their team members in radiation, surgery, medical oncology. And then the treating team is supported by allied health providers that are shown in blue. Examples of this include nurses, audiologists, speech pathologists, dentists, dietitians, social workers, all with the goal of trying to support the patient at the center of this diagram. And specifically when we're thinking about the allied health providers, a lot of the support comes with management of side effects. So national guidelines recognize that the best time to start supportive care or side effect management is actually before treatment. And here you see a screenshot of the principles of nutrition management and supportive care for head and neck cancer from the National Comprehensive Cancer Network. And specifically, I've blown out the section on swallowing supportive care. For swallowing, pre-treatment evaluation and consultation is actually recommended for patients who have pre-existing swallowing dysfunction at the time of their head and neck cancer diagnosis, but it's also recommended for people who are having no impact to their swallowing, but whose treatment is predicted to likely influence the swallowing function over time. The reason for this is to try to integrate the concept of prehabilitation into the process of cancer care, and particularly with regard to swallowing. Here you can see prehabilitation defined, and it's essentially starting therapy before a problem is bad. In the context of cancer, this is defined as a process that begins between the time of a cancer diagnosis and the beginning of treatment, in which a therapy is aimed to reduce either the development or the severity of a current or future impairment. Swallowing prehabilitation is actually very popular in the head and neck cancer care and has been described in the literature for now more than 15 years. Here you see just one example of a review article that tried to summarize close to 30 articles on the topic that have been published since 2006. And the consensus from this work was that there was evidence to suggest that prehabilitation for swallowing is beneficial, but that the optimal design of how to implement this into an individual patient's care is still not yet known. In general, all forms of swallowing prehabilitation or preventive swallowing therapy in North America tend to integrate the speech pathologist early in care, trying to promote the philosophy of use it or lose it. And that idea is to try to maintain swallowing function by keeping the swallowing system active through the head and neck treatment journey. This can be done by helping the individual patient try to maintain oral intake, that is, keep eating even when it hurts, even when it tastes bad, keep eating the most challenging and safest foods to keep the system functioning. And sometimes this might also include adding swallowing exercises, even in the absence of an active swallowing problem, to try to keep the swallowing musculature at its optimum function for long-term recovery. So with that in mind, what I'd like to do is transition the conversation to Ed to sort of add into the clinical perspective that I've provided about what we're trying to accomplish with swallowing, some of the patient's perspective and how we might navigate diminishing that overwhelming aspect of this goal.
Thanks, Kate, for sharing your insight on this question. I'd like to thank our program hosts as well. I listened in on yesterday's session, and each one set a very high bar. It's an honor being a speaker here today. Being on the agenda is especially meaningful to me, as there was a time I didn't know if I would ever be able to talk again. So this ties into the point that Kate made, to use it or to lose it. And as Bill mentioned in her introduction, I'm a head and neck cancer survivor and president of the National Foundation of Swallowing Disorders. And I'd like to share a bit about my own cancer journey before talking about handling life after a head and neck cancer diagnosis. I was just like many of you, a parent, a spouse, a business person, when late-stage cancer came knocking at my door 17 years ago. This slide highlights a treatment timeline. In the 2.5 years following my initial diagnosis, I had a constant stream of treatments that were met with 4 unrelenting recurrences. Cancer took my left jawbone and teeth, part of my tongue, part of my soft palate, my fibula bone from my leg to replace my jawbone, along with my ability to speak and eat. It would not stop. In the 2.5-year period following my initial diagnosis, I had 36 radiation treatments, 6 surgeries, one being an 8-hour salvage surgery, and 8 different chemo regimens, some of them lasting as long as 8 months. Due to the research conducted at MD Anderson, an effective chemo regimen was identified that finally stopped the recurrences and cured me. I've had no evidence of disease for 14 years. I owe my life to my medical team at MD Anderson, and I'll always be grateful for their knowledge, their multidisciplinary approach to patient care, and to the physicians and therapists who actually listened to me. So that's a condensed version of my cancer journey. And now I want to share with you what I learned to help others navigate a new head and neck cancer diagnosis where dysphagia may come into play. A cancer diagnosis happens in the blink of an eye with 3 little words: you have cancer. So what can you do if this happens to you? First, become an effective self-advocate. You are your own best advocate, and a spouse or other caregiver is important, even if you can advocate for yourself. So what does being an effective advocate mean? First, knowledge is power. Scour the internet for information on your cancer type. Learn the lingo. Understand the protocols around radiation, surgery, and oncology. Prepare and write down your questions before each appointment. Also, recognizing that different people process and retain information differently, a journal of your visit can be invaluable. Second, research and choose the right facility. Life-saving head and neck cancer treatment impacts can be brutal, with lifelong side effects. Choose a facility that has a proven track record with a high volume of patients. Ask yourself, do you want to be treated by a head and neck cancer doctor who sees a few patients a month or 50+ patients a month? Experience counts. In addition, Due to the complexity of head and neck cancer, a truly integrated, patient-centric, multidisciplinary team is essential. Third, I call it a helping hand. Seek out someone who has walked in the shoes you are about to fill. If you think your treatment plan may result in a swallowing disorder or other significant side effect, short or long term, ask to meet with a patient or two who has been through a similar treatment plan. I encourage one-on-one interactions early on. The closer your contact is to your treatment path, the better. It was invaluable to me. After advocacy, my second piece of advice is to listen to your medical team and ask for clarification if you don't understand. For example, if you're undergoing radiation treatment and your medical team recommends prophylactic oral exercises, follow their advice. Kate covered this in her talk. If I hadn't followed my team's advice, I'd be listening to this talk today, not giving it. Next, understand each provider's role. As Kate pointed out, there are many disciplines involved. Your head and neck cancer doctor should be guiding you to the right medical team member at the right time. If you find yourself questioning why you're seeing a particular practitioner, ask. You were sent there for a purpose, find out what it is, and keep asking until it makes sense to you. There are other key emotional points that I cover, such as learning to live with uncertainty and emphasizing the importance of use it or lose it mentality. But due to time, let me turn this back over to Kate for question number 2.
Thank you both for that so far. Our next question was, I'm now done with my treatment, but continue to have trouble with dysphagia and gaining weight. My providers say everything looks okay. Do you have any suggestions? Help.
Thanks, Phil, and thanks, Ed, for those really helpful sort of pointers on how an individual can help to try to decrease the overwhelm. And what I take away as the key messages is self-advocacy and the importance of asking if it's unclear. We're all here, and I think at one point Ed said, you know, what do you think is the number one most critical factor that makes a good provider? And my guess was listening. And Ed said spot on, right? And so just like we need to listen to you, it's important that we hear your questions. And so please do ask anytime you need clarification on why you are somewhere. So getting back to this second question, I think the second question is really focusing on the scenario where, despite our best efforts at trying to use proactive supportive care or prehabilitation strategies, the recovery falls short of the goal. And when an individual is experiencing swallowing difficulties after they've finished head and neck cancer, it's a complex scenario. These swallowing difficulties that either arise or persist after you've recovered from your cancer treatment are not all alike. And there are many factors that can influence both the nature and the severity of difficulty with eating or swallowing in short and long-term cancer survivorship. And some of those factors are shown on this slide here. Some of them are related to the head and neck cancer itself. So the size and the site of the tumor, what is the function of the structure that the tumor arose that in normal swallowing, and that'll impact, how swallowing is affected by the tumor itself. And then the details of how it was treated, the type of surgery and reconstructive methodology are really critical if surgery is used. And likewise, radiation is not all equal, and there's a lot of variation with the dose and the field or the tissues that are actually in the radiation path, and that will absolutely dictate the change in swallowing system. But not all of the factors are related to the cancer or its treatment. And in fact, some of the factors are just related to the patient themselves and who they are outside of their cancer. So some things that are really critical are things like age. We know that just as we get older, the swallow becomes slower and a little bit weaker. There are a number of other medical conditions outside of cancer that it can influence the swallowing system. And so these other factors that the patient brings to their head and neck cancer scenario are also very important and often influence what we refer to as functional reserve, or the ability of an individual who's going through treatment to sort of compensate for some of the injury that may happen with the cancer itself. So the first step in helping swallowing difficulty is understanding what's driving the swallowing change. And here you see just a diagram to help understand some of the potential sources of swallowing difficulties. So if an individual is experiencing difficulty swallowing solids, it could be due to a variety of factors, one being inadequate push on the food or liquid bolus by the tongue or the squeezing, constricting muscles of the throat. We call that poor propulsion. It could also be due to actually a mechanical obstruction or a narrowing in the passage, particularly at the bottom of the throat where it connects into the top of the esophagus or the food pipe, referred to as a stricture. And sometimes it's actually related a little bit higher up in the system in the mouth to just inability to effectively prepare the food for swallowing. So perhaps a reduction in saliva for mixing food, or just an inability to chew altogether. Any one of these factors alone can cause difficulty swallowing solids, and it's not uncommon for them to coexist. But their treatments are quite different, and so identifying the primary source is going to drive effective management. Likewise, for difficulty swallowing liquids, we often, in an individual who is reporting this challenge, are concerned about a problem called aspiration or the entry of liquids into the lungs during swallowing. But aspiration in and of itself can have a variety of causes, and we have to uncover that to try to best manage the situation. So aspiration can be due to a reduction in airway closure during swallowing, but it can also occur when the airway is closing properly, but there's stuff left behind after swallowing that's falling into the airway as you relax to breathe. And so it's really critical that we get high level and accurate imaging to understand the actual swallowing process in a patient who's having dysphagia symptoms in order to effectively match the right treatment. Here you can see some of the key components of a comprehensive swallowing evaluation. These are by no means the only elements of the examination, but some of the more universal and critical factors. This starts with imaging of the swallowing process that can be done primarily with either X-ray, a procedure called a modified barium swallow study, or video fluoroscopy is very frequently used. And its endoscopic sister is a procedure that's sometimes referred to as FEES. With any of these evaluation procedures, what would happen is under imaging, an individual would be asked to swallow a standard series of foods and liquids, and the provider is evaluating a variety of things, but specifically the efficiency of swallowing, which is how quickly and how completely the food or liquid bolus is cleared out of the mouth and throat and into the digestive tract. We also evaluate the safety, which is how well the food and liquid is kept out of the lungs. And then finally, we look at the physiology of swallowing, which is looking at the component pieces of the swallowing mechanism and how they're moving to move the bolus along its path. We don't want to stop with just this imaging study. We want to match that with some of the other elements that are really critical. This includes the integration of what we call patient-reported outcome measures. These are those questionnaires that ask you to scale different elements of what you're experiencing. Really critical to match what the patient is perceiving with what we're seeing on imaging. And finally, to understand the functional status of the individual patient undergoing evaluation, and specifically with swallowing, a lot of that centers around what you're able to eat and what you're not able to eat, or what we call your diet level. The evaluation procedure will help us identify the appropriate treatment. So on this slide, you see the options, some of the primary options for non-medical or behavioral swallowing therapies. In North America, these are largely provided by a speech-language pathologist and might include exercises, hands-on tissue manipulation, or training in a particular pattern or strategy to swallow more effectively. And this can be done with or without exercise and therapeutic devices like you see pictured here. In general, these treatments are designed to potentially improve either the mobility of swallowing structures, the strength of swallowing structures, or the actual skill or pattern of the task. There are also a number of medical and surgical options that are predominantly done by an otolaryngologist, ENT, or a gastroenterologist. Some of the more conventional medical and surgical options are shown on the left-hand side of the slide. Dilation is an endoscopic procedure that stretches a narrow passage in the throat. Tracheostomy is the insertion of a breathing tube, which is rarely done for dysphagia, but can be done if secretion management is not adequate for uncontrolled aspiration. And then on the end stage here, total laryngectomy or complete surgical removal of the voice box is a quite aggressive procedure, but can be done to more definitively control aspiration if all other procedures are failing. I highlight on the right-hand side of this slide some of the investigational medical and surgical procedures that we find currently under investigation on clinicaltrials.gov. This is only a few examples, but to show that a great resource for individuals who are looking for treatments that might still be more in the experimental phase is a registry called clinicaltrials.gov, where you can search for any active research studies that are looking into these types of investigational procedures. The final resource I'd like to leave you with is the American Board of Swallowing and Swallowing Disorders, or the ABSSD. Provides designation for speech pathologists with advanced practice skills in the area of dysphagia. And so if you're looking for non-medical therapies by a specialist in your area, they do have a provider search tool on their website that can help identify somebody who has reached advanced certification in this area of practice. With that, I'd like to hand back to Ed for your input on some of the patient's perspective on these post-treatment dysphagia challenges.
Terrific. Thanks, Kate. I do have some suggestions and basic information that I'm hoping will be helpful. The root cause of dysphagia is generally classified in 1, 2, or 3 anatomical regions: the oral cavity, the pharynx, and the esophagus. The head and neck cancer population will be primarily affected by the first 2 areas. The oral cavity is important as this is where food is masticated. A bolus is formed with a lot of help from the tongue. If there are deficits in one's ability to chew, to form a bolus, or use your tongue to move that food bolus to the back of your oral cavity, or as Kate said, propulsion, this can impact the ability to swallow safely and efficiently. The pharynx is critical due to the complexity of what happens when you swallow. Your epiglottis, which is attached to the base of your tongue, is lowered by the base of the tongue to protect your airway. Your hyoid bone right here raises forward and food moves smoothly from your oral cavity through the pharynx and down your esophagus to your stomach. In a normal swallow, this all happens naturally. I was diagnosed with severe dysphagia following a modified barium swallow exam in 2007. I have 3 primary deficits that affect my swallow. My tongue is very weak. My epiglottis doesn't protect my airway, and a large hole in my soft palate presents further complications. Each patient with dysphagia will have his or her own issues. So, turning back to the question of navigating post-treatment world and how to address a swallowing deficit, I have a list of suggestions. First, consider a feeding tube. This may be for short, medium, or long-term use. It can provide the nutrition you need for your body to heal and become healthier. Feeding tubes have a valid medical purpose in our community. Next, establish a strong foundation for your recovery by adhering to the following recommendations made by your medical team. Following treatment, you will be placed on a schedule. Depending on your diagnosis and treatment, it may begin weekly, monthly, and eventually taper off to annually. This is important to identify and address post-treatment issues quickly, including dysphagia. My speech language pathologist was an integral part of my recovery team following my salvage surgery. I had a feeding tube for 3.5 months after that surgery. Without my SLP, who was constantly coaching me in stretching and range of motion exercises, who provided me with recovery appropriate foods to try, and who also taught me a swallowing technique known as the supraglottic swallow, I would most likely still be on a feeding tube. That was 15 years ago. Maintain your nutritional intake. You may not want to run through all your, or you do not want to run through all your reserves and become underweight and malnutrition. If you need a nutrition drink to gain or maintain your weight and nutrition, use them. In consultation with your medical team, consider anatomy appropriate foods and liquids as soon in the recovery process as practical. Take advantage of swallowing rehabilitation. If you've chosen, pardon me, if you've chosen the right facility, they will have you covered. Set mutually agreed upon goals and work toward them. If your healthcare provider isn't helping, find a new provider. Speech language pathologists are the discipline you want to seek out to address swallowing deficits. And I would do this sooner than later. The longer you wait, the harder it will be to recover. Muscles not in use atrophy quickly. Maintain your oral health. If you've had radiation to the head and neck area, it has more than likely affected your salivary gland and the amount of saliva you produce. Dry mouth not only feels uncomfortable, but is an invitation to tooth decay. There are lip balms and gels to alleviate some of the discomfort. Recognizing my own somewhat lax mouth care routine, I began having my teeth cleaned every other month to quickly identify trouble spots. Unfortunately, the pandemic interrupted that. Next, know your body and don't ignore the signals it is sending to you. If you're losing weight unexpectedly, something is wrong and you should find the cause quickly. To gain weight, look carefully at your calorie consumption. I spent a summer drinking large milkshakes daily. Consider some tools. I know many head and neck cancer survivors use an inexpensive home suction machine to help clear their oral cavity and to reduce the phlegm buildup that so many of us experience because we can't swallow normally. There are also existing and new rehabilitation tools on the market to help with rehabilitation. Research them. And while not necessarily dysphagia specific, find your new normal when you are ready to find it. Many people want to get back to their old normal. It is who they were. I advise proceed with caution. Treatment is not a walk in the park, and recovery takes time. I know of a few patients who move too quickly to get back to their old normal and were met with poor outcomes, including aspiration pneumonia and choking. A helping hand in the post-treatment time frame, this is vastly different than in the diagnostic and treatment period. I suggest participating in a dysphagia support group. This could be online, real-time virtual, or in person. You'll learn how others who are walking in your shoes are coping with their new normal. Our foundation provides all three of these dysphagia support group participation options. And you can find out more by reading about them online at our foundation website or reaching out to us. And last, consider keeping a journal. It can be about anything and provides an outlet for your well-being. So with that, let me turn it back over to Kate for question number 3.
All right, I know we're getting close on time and we have lots of great questions in the chat, but we had one more we're going to briefly go through and then we'll move on to the questions. I have a severe swallowing disorder and it has a huge negative impact on my quality of life, socializing, eating out, partner relationships, traveling, and my mental health. How and when will my quality of life improve? And as a caregiver, how can I help?
This is a great question, and I actually just have one slide, and I think it really ties into much of what Ed has already shared from earlier conversations about listening and asking for clarification and really helping to ensure that both the clinical provider and the patient and family are as close to being on the same page as possible. And so what I would say is that the quality of life impact of severe and particularly lasting long-term dysphagia, both for head and neck cancer and folks who have dysphagia for other causes, is enormous. And as a clinical provider, one of the areas where we focus our goal setting when we're looking at providing either medical or behavioral therapies is often in this sort of cog in the wheel at the bottom of the slide of what we would call the physical impairment. So I see that the passage is narrow and then we're going to send you to get it stretched. Or I see that your base of tongue is weak and so we're going to give you exercises to try to strengthen that. But those are just the physical aspects of swallowing. And what this figure or diagram is designed to show here is that there's a very dynamic interplay between the physical aspect of swallowing, the functional aspect, meaning what you can eat, the psychosocial aspect, how it impacts you and your day-to-day. And what I would ask as a clinical provider is that we share in the goal setting so that I can try to tailor the therapy to meet your primary goals and what's impacting you the most. So for instance, if you come into therapy and I'm just going based on the imaging, I might spend all of my time planning your therapy based on what I see on the imaging. But if you say to me and we come together and shared goal setting and you say to me, my number one priority is to drink champagne at my daughter's wedding in August, then I have a very clear goal and I will direct my therapy to prioritize that first and foremost above making your tongue base move better. And so that's where we can help each other work better and more effectively together. If you say to me, I really just want to, I want to eat everything, but my number one thing I missed eating is oysters, then we have a goal and we're going toward that first and then everything else next. And so that would be my input on this question. Ed, I would love to hear your input on it as well.
Terrific, Kate. Yeah, I think the point that you made about having shared goals is so important, and to be able to articulate them. Let me jump in, and I'm going to be brief also. I want to recognize the wide range of impacts from head and neck cancer treatment. They may be negligible or they may be huge. Everyone is different. And I'm going to assume a moderate to severe dysphagia in the remarks that are coming up. You may not realize it, but eating uses all 5 senses: vision, touch, smell, taste, and even sound. And all of these senses are important to the eating experience. Discuss the use of foods appropriate for your current swallowing ability and discuss them with your medical team. There are some new transitional foods on the market that are worth exploring. There are too many social coping mechanisms tied to dysphagia for me to cover them all. I've learned these from talking with fellow patients and healthcare providers, and here are some of my favorites. Even if you can't eat in public, order something when you're in a restaurant. The wait staff will leave you alone and the other guests will feel more comfortable. If you're having trouble with drooling or saliva, wear an absorbing waistband to discard saliva discreetly. If you are with a group, plan ahead. Know where and how your next meal is coming from. And travel in the US, there's now so many options for shipping nutrition ahead. Non-US, at the moment, pack what you need. The caregiver spectrum is huge due to patient requirements and other factors. Caregivers can make appointments, participate in appointments, help maintain social ties, tend to wound healing and nutrition. They can be a huge part of your support system. My spouse helps me frequently. First off, she's brighter than I am. She helped me with this talk. I'd like to leave you with one last thought, and that is of acceptance. There are 5 stages of grief. The first stage being denial, with the last one being acceptance. I've witnessed head and neck cancer survivors in each stage. the people who seem the most healthy, happy, successful are those who are in the acceptance phase. And acceptance today doesn't mean surrender. It doesn't mean giving up hope. It means, here's who I am today, and I accept that. Tomorrow will be a new day and new challenges and maybe new achievements. I'm not a psychologist and can't coach you on how to get there, but I hope we've given you some food for thought in our dysphagia presentation that wasn't too hard to swallow. And with that, Bill, let me turn this back over to you.
Okay, thank you so much, Ed. I'm going to start firing away with some of these questions that we have, and hopefully both you and Kate can jump in. So the first one came from Judy Burton. She's a 17-year head and neck cancer survivor with continued challenges with swallowing. She's had several esophageal dilations and would like to love to know what long-term survivors can do to help with this ongoing problem. Any advice or thoughts?
Kate, do you want to take
Sure.
that? Or?
You know, late effect, I wrote back to one individual in the Q&A box on the topic of late dysphagia, and it's a real problem. And we actually coined or use the term late RAD for late radiation associated dysphagia, which is a phenomenon where, you know, years after recovering a reasonable amount of swallowing function, you start to notice a decline. What we know about late dysphagia, particularly after head and neck radiation, is that there tends to be, if there's nothing done, it tends to have a progressive trajectory where the swallowing ability can progressively worsen over time. We don't have a treatment that completely reverses it back to its pre-treatment stage, but what our current treatments are really targeting is to try to pull it up and make that and pull up the slope of that change to more of a flat line. In general, with late dysphagia, esophageal dilation by itself tends not to be enough, because what we see is often there's a big issue with the squeeze or the push of the swallow, not just the narrowing of the pipe. And so we tend to couple dilation with behavioral swallowing therapies. We run a therapy program at MD Anderson called Boot Camp, which tries to sync up exercise and functional therapies to try to get that line as high as possible. There is no sort of gold standard for late dysphagia, but we do think that the patients that do best with delaying and improving that progression are those that really tackle, as soon as you have those symptoms, tackle it with intensive combination of both medical and behavioral therapies. So that means seeing a head and neck surgeon or GI, as well as a speech pathologist, and getting combined therapy from the two teams. I hope that answered that.
That's great.
I'll also put my email in chat, so you can feel free to email me if you need more.
Same for me. If someone can put my email in the chat, people are welcome to reach out to me.
Great, thanks, Ed. I'll add that in then. Quite a few people will ask if they can contact you outside, so I will add that in, or maybe Amanda can help us with that. Another question we have is, how does neck dissection affect swallowing and challenges after the cancer treatment? I think I can start a little bit with this from the surgeon side, but then hopefully Kate can jump in on the post effects. I think with the neck dissection, a little bit depends on exactly what's involved and what the neck dissection is for. Some patients, if they have a large persistent neck node that's causing some external pressure, a neck dissection can help, but it can also hinder, depending on how aggressive the surgeon needs to be. You can affect some of the nerves that either control the tongue or the pharynx, or even further down the line, just getting close and causing more scar tissue. I think those are the effects that we see from the surgical side, but things such as radiation fibrosis or scarring afterwards can really have a big effect as well.
Yeah, I mean, I think that neck dissection is one of those factors that, unless it's a more comprehensive neck dissection where they're taking out lymph nodes in certain regions that are very close to nerve tracts, I don't expect typically to see a pronounced dysphagia that's directly caused by the neck dissection. And we've actually published things in this space that a highly selective neck dissection that's just a few at-risk nodes away from nerve tracts in and of itself doesn't differentiate patients with, severe dysphagia from others. That said, one of the things that I feel like we can physically see and feel is the increase in the scarring around the neck dissection incision in a patient who also has radiation in that injury. So if you have a patient who's had just radiation, and then you have a patient who's had radiation and neck dissection, and you feel their neck, it doesn't take any sort of advanced medical training to say that neck is typically harder than the neck that didn't have a neck dissection. So what I'd say about that is that particularly if you've had a neck dissection with radiation, I would be more inclined to feel like manual therapies, hands-on manipulation of the scar line, cervical stretching, prophylactic exercise may be a little bit more important in that setting because you have that added risk of scarring.
Let me also add in, it depends also a lot on the person. So someone who is going in healthier than not is going to have an easier time and may be a lot less impacted by someone who is less healthy. So it's very personal as far as the impact.
All right, well, again, I'd like to thank everybody for all the survivors and caregivers for your attendance today. Special thanks again to Dr. Hutcheson and Ed for their time and their insight, as well as the Head and Neck Cancer Alliance, the American Head and Neck Society, and everyone for hosting this webinar. Thank you to our sponsors who are going to be shown on the next slide. And please take a minute to do the poll at the end to signify if this is helpful and let us know how we did. Thank you, everyone.
Thanks so much.